So this is the shared care record that we've designed in the Clinical Design Authority, which is around frailty and dementia. And essentially what it does, it pulls demographic data from the GP system, so the patient's details, their GP details. You can input things around accommodation and where they live and whether they're independent or have carers and support. And also the access to that property. There is also another section here which is around health matters for people with dementia and frailty. And in this is a lot of useful information, I feel, that can be inputted by community services around mobility, around nutritional status, around hearing and sight and communication, and all of that is very important in making arrangements for patients, not only on admission to hospital, but more importantly on discharge from hospital. We've also added in a News 2 score as a baseline so that we can see deterioration in patients. A lot of the frail elderly patients will have a baseline of a high News 2 score, and if you're able to share that information across to a trust on discharge, it's less likely to delay their discharge because they have a high News 2, because they know that their baseline is higher in the community. Also, we've put in a legal section there around DOLs and mental health and lasting powers of attorney. And then there is the dementia section and the frailty section, which, depending on the diagnosis of the patient, you can click onto. So if I was to click onto the frailty, it will show you their Rockwood score, their EFI, and also a diagnosis of mild, moderate or severe frailty, and then a falls risk assessment would be done for that patient, which is really important to be shared across the community. Another thing that we've recently added is also the MDTs that happen in the community and which services that patient would be under the neighbourhood. So for in Tameside and Glossop, they may well be under the community physios, the extensivist team, community pharmacists, and it's really important to know which teams are involved in that patient's care. And once this record is updated, it can either be updated in the EMIS system and pulled onto this system, or be updated on the Black Pear system itself and be pushed back onto EMIS, or pushed onto Lorenzo, or pushed onto community EMIS as well.
I think it's really good for us as community services that we'll actually all be able to see what each other's doing, so that we're not duplicating our work. And it's not causing us additional work to do. But I think from a patient perspective as well, it's good that the patients don't have to keep retelling different health professionals the same information over and over again, which can get quite tiring and frustrating for them. Having different professionals being able to input into the record adds richness to that patient record from those other health professionals' different experiences, because we will all look at the same situation and assess that very differently.
One thing that we're doing in Tameside for frailty is that once a patient has been given a Rockwood score, that then allows you to make a diagnosis of mild, moderate or severe frailty. If one was to click on the severe frailty, it would then ask the question as to whether an EPACS is in place for that patient, and allow you to go on to create an EPACS, which is an end-of-life coordination system for those patients in terms of advanced care planning, their preferred place of care, and also their whether they have any things like a DNA CPR or a lasting power of attorney in place. And that's really important to share across the system when these patients are being admitted through, say, the ambulance service or out of hours service. So it allows that clinician to make a decision as to whether it's best to keep that patient in their own home and care for them there, or to actually admit them to hospital. By having a record that's being able to be written into at any point in that patient's journey allows for that single version of the truth that we talk around. So it allows for not only hospital clinicians but also GPs and healthcare workers to update and upload that information straight away. And I don't think we've ever had that in the NHS before, where we've had bi-directional flow of information between primary, secondary care and community care.